Well, Dr. Yeager, do you think we should begin? Okay. Welcome, everybody, to the first in our limited series of the Consortium for Workforce Research and Public Health Year 1 seminar. We are here today with a group of growing folks who are interested in hearing about the Public Health Workforce Research Center's projects in the first year. This is funded by an award from HRSA and CDC. We are the National Public Health Workforce Research Center operating under the Consortium for Workforce Research and Public Health. You'll hear that called CWORPH. So today we're pleased to be presenting the first of our 10 projects in year 1. You'll hear from Dr. Valerie Yeager, Dr. Paula Kett, and Dr. Betty Bekemeier. I'll introduce the presenters and then ask them to get into it. My name's JP Leiter. I am at the University of Minnesota. I direct our Center for Public Health Systems, and I'm one of the PIs on the Public Health Workforce Research Center. So up first will be Dr. Valerie Yeager, who is a professor in the Department of Health Policy and Management at the Indiana University Richard M. Fairbanks School of Public Health. Dr. Yeager's research broadly focuses on the intersection of healthcare and public health systems, including studies of nonprofit hospital community benefits, community health needs assessments, wraparound service provision, and care coordination. In the field of public health systems and services research, Dr. Yeager studies voluntary national accreditation of public health departments and workforce topics such as recruitment, retention, and training needs. And then after Dr. Yeager, you'll hear from Dr. Kett and Bekemeier. Dr. Paula Kett is a nurse scientist at the University of Washington's Center for Health Workforce Studies with expertise in public health systems and perinatal health, and has experience using both quantitative and qualitative methods to conduct equity and systems-oriented research focused on the health workforce and addressing perinatal inequities. Dr. Kett has conducted and collaborated on mixed methods research on public health systems, public health nurses, and the perinatal health workforce, as well as health inequities. Dr. Bekemeier is the Kirby and Ellery Kramer Endowed Professor at the University of Washington School of Nursing and Director of the Northwest Center for Public Health Practice. Betty is a nationally recognized public health systems and practice-based researcher with a particular focus on the structures and practices of state and local health departments in relation to health outcomes and reducing disparities. Betty is also a national public health nursing leader, having served in national positions of public health and public health nursing. So what we'll do is we'll hear from Drs. Yeager, Kett, and Bekemeier in 2 presentations. If you have questions, I believe we have a Q&A here that you can post into. So throughout either presentation, if you've got questions for the presenters, please put them there. Feel free to put chat in the chat with each other if you'd like. And then we'll answer questions as we're able. We'll have about 20 minutes, we think, at the end for questions and answers, and we'll go from there. Dr. Yeager, please.
Thank you, Dr. Leiter. 1 second. You should be able to see my screen.
Yep.
I'm presenting on a study called the Public Health Workforce Recruitment, a review of state hiring laws. And I want to start by acknowledging 2 of my co-authors and colleagues on this study. One is Molly Demosthenes, who is now the dean of the undergraduate college at Tulane University, but was faculty with me when I was a faculty member at Tulane University and has a JD. So she has helped us review the laws and pull the data that we will synthesize in this study. Ashlyn Burns is a doctoral student at Indiana University Fairbanks School of Public Health, where I am faculty. I want to give them credit for their contributions. As background, civil service laws were put in place through a number of policies and were essentially meant to prevent cronyism and to insulate the public employees from political influence. Critics have historically argued that these laws impose an undue burden on hiring managers. And over time, as a result of some of those critiques, civil service reforms have sought to expand managerial flexibility to be able to hire or dismiss employees as needed. More current reforms attempt to improve personnel management by making government systems less rule-bound, more flexible, and more responsive. Governmental public health agencies are a part of these civil service or merit system hiring laws where applicable. And so those state agencies also are part of the context around these laws. And in particular, governmental public health agencies have experienced long-standing challenges in recruiting individuals at the state and the local level. We saw this during the pandemic as health agencies were attempting to hire new employees and were struggling to be able to do so quickly. We have lots of recent evidence about the shortages in the workforce and documented experiences of trying to hire. So the civil service system ends up often being anecdotally referenced as a reason for some of these hiring delays and other hiring challenges. And as a first step, understanding the laws that govern the merit system or the civil service system and how they relate to the hiring processes, we first need consistent data collected across all states so that we know what those laws look like and can then examine the laws in the context of other recruitment related variables and experiences. So the purpose of this study is to identify and catalog the state hiring laws and the regulations that govern the public health governmental workforce. And we provide the current state hiring laws and regulations across all 50 states in this study, where we summarize and we also map them. So for some methodological background, we used legal mapping techniques to collect and code data on the current laws and the regulations for all 50 states. We developed a question development table, or a QDT, that contained 13 questions regarding the merit system and the hiring laws. And there were 8 parent questions and 5 child questions conditional on the response to the parent question. Information on state hiring laws was cataloged in an Excel file developed in alignment with the QDT. It maintains the reference to the statute, the regulation, or the administrative code that provides the detail for that answer. And as one definition that's really important to our study was the definition of a merit system. So we defined this as a process for promoting and hiring government employees based on their ability to perform a job rather than political or other connections. We collected our data between June 1st and June 30th of 2023. Searches were conducted in the Westlaw legal database as well as state agency websites, using appropriate search terms that were relevant to the parent questions. All data collected were based on the laws that were in effect as of June 1st, 2023. We provide in this study descriptive statistics to summarize the legal landscape across the states and corresponding maps to provide a visual representation of specific key variables of interest. Nearly every state has a merit system requirement in place, which applies to at least some governmental positions, with Montana being the exception. Montana does not have a merit system specified in the law. Again, we use that definition of the merit system. So if they don't explicitly say it's a merit system, but they use something that exemplifies that definition, we count it as a merit system. A total of 48 states require criteria to be used when hiring public employees, and nearly all of these have merit system requirements that apply specifically to public health professionals. And I want to just pause for a second and say what happens in practice and what some of you, if you are practitioners, experience may not be exactly what I'm presenting today, because what's codified in the laws may look different than what happens in practice. So this is the first step of looking at what the laws specifically say. Several states have laws that exempt certain public health professionals from merit system requirements. The most common are exemptions for agency staff or executive staff. That's occurring in 39 of our states in their laws. Physicians are next, 1 out of 5 states. Pharmacists, nurses, and are similar in about 2 or 3 states have the exemptions for them. And then a lot of states have this other written into their law, which is sometimes defined as individuals who engage in public work that is funded by the federal government, or what are called, quote, policy influencing positions can also be exempt from the merit system requirements. I'm showing one of the main tables from this study, and as a note, the study is under review, so it hasn't been published yet. But the main table that comes out of the study synthesizes which states were coded according to the different variables that we collected information on. And so this first one that I'm showing you is about civil service exam requirements. We've heard a lot from health departments about the challenges of the civil service exams. So understanding what the law says regarding the exams is important for our preliminary work. In about 3/4 of our states, the law establishes a civil service requirement without specifying conditions. A civil service exam is referenced in 3/4 of the states. So it's at least mentioned in the law across 3/4 of the states. But without saying specific conditions, some of the laws just simply reference it. Another 12 states, or 1/4 of our states, do not require a civil service exam or have no mention of it at all in the law. And then we looked specifically if the law indicated that there was something about a civil service exam or it's a possibility to require it. We looked to see what are the criteria for how the exam can be administered. And these are not mutually exclusive. Some laws say it can be a written exam. Some laws say it can be a written and an oral exam, or an oral exam, and so on. And so we code these as if they were independent of one another. And if a state said written, education can be used as a quote unquote exam, or previous performance could be used as quote unquote an exam requirement, then we code it for those states that use that language in the law. So many of the states, about 58%, have written exams, oral exams, allow for education, allow for performance, and then half of them have very broad language that doesn't specify any kind of administration of the exam. And then some say nothing. So those are the ones that are unspecified, so 4 of our states. And then 12 are not applicable because they don't reference the civil service exam in the laws at all. The next question that's important is who administers these exams? So we've heard from individuals in states that the administration of the exam is not frequent. And so understanding how these exams are administered or who's responsible for them is important. And in terms of the administration function, public health agencies, according to the law, can administer the exams in about 1 out of 4 states. And about 2 out of 3, or 62%, have the administration of the exams by an external agency, so separate from the public health agency. And within our legal review, only 3 states mention anything about a civil service exam fee. So the specifics of how this is being done is not necessarily codified in the law. It's usually written into organizational processes from what we found from our analysis. Here's a map of what the states look like according to their criteria for civil service exams. So they're white if they have no exam requirement written into the law, green if the law requires an exam but doesn't specify the conditions. Yellow if the law actually specifies the conditions of the exam, red if it states that an exam could be required, and blue if it allows for an exam but does not require it. In addition to the civil service exams are hiring lists as one element of the step in the process to get hired through merit systems. And so we wanted to be able to understand what the laws say about these lists and who manages the lists, and whether there's guidance for preferences from any type of individual on that list. And so only in about 1 out of 5 states does the public health agency maintain the list. 60% of states, another external agency maintains the hiring list. And almost 70% of states require, according to the law, that selection for new employees be made from this list. 28% of states have no requirement for a list. And then we looked at whether or not they had hiring preferences to certain individuals. And this occurs in all but 2 states. So 96% of states do have hiring preferences written into their laws. So what do those preferences look like? Almost every state, so 96% again, gives preferences to veterans, a smaller proportion to those family members of veterans, so 60% to family members. 30% of states to current employees within the governmental public health system, 28%, just about the same, to former employees within the system, and then a fraction, a very small percent, to individuals with disabilities, just 4 states. State residents get hiring preference in 4 states. And then 1 state gives preference to Aspire job participants. And Aspire is a temporary assistance for needy family program that helps recipients move towards employment through case management. So they've written that preference into their law. What was interesting in our review is that no states offer any hiring preferences for people who participate in a formal public health fellow program. So these include, we specifically went back and we looked for any language related to these fellowships. That could be the Public Health Associate Program, the Epidemiological Intelligence Service Program, or EIS, the Public Health Informatics Fellowship Program, or even though very recently named, the Public Health AmeriCorps Program. None of these are given preference according to any of their statutes or regulations or administrative codes. And that's particularly interesting because we expect that individuals who are participating in these fellowship programs are meant to be fast-tracked into employment in the governmental public health system. It's meant to be a recruiting tool and a training tool. But as we have found in the review of the laws, there are no preferences for these individuals. Here is a map of what these hiring preferences look like. And so you'll see we've created symbols and color-coded those for individuals that are able to use that to discern the differences. But we've got family members of veterans as a red person-like shape. The yellow star is current employees. The green circle is former employees. A plus is individuals with a disability. State residents get that blue house shape. And Just Maine has that Aspire job participant briefcase. So if a state has no hiring preference, it is considered gray. Or, sorry, blue, actually. So the legend is wrong. That's supposed to be blue. So some key takeaways from these findings. The laws that govern the merit system and the civil service system vary. And according to what's in the law, there's a bit of a lack of clarity, which may be difficult for agencies or potential employees when it comes to understanding the system and navigating it. Almost a third of states have laws that establish a civil service exam requirement without specifying conditions for when exams must be required or for which types of roles or employment. Requirements for state hiring lists also vary. In the majority of states, another external body manages and maintains that hiring list. And that's almost 70% of the states that are require a list, require that selection come from the list. This process could be also confusing for potential employees in terms of how to get onto a hiring list and the time it might take to get onto a hiring list, especially if the civil service exam is a requirement before getting on that hiring list. And then also unknown is how long does one's name remain on these hiring lists. It's feasible that the process of reviewing applicants, when removed from the public health agency and the hiring team that will actually employ that new worker, is more bureaucratic and time consuming, which is something that we've heard frequently when speaking to hiring managers about recruitment issues. And unfortunately, this might mean that recruitment of the most qualified applicants may not occur, as those individuals may be in high demand and receive offers from organizations that can move faster and provide an offer quicker. Given the experiences of some of the states or state agencies that were using the American Rescue Plan funds to recruit into their workforce, even states that tried to establish their own public health corps, the merit system and the civil service requirements still served as barriers to being able to recruit using those dollars, which were time limited. So some next steps for this work, we are engaging in the second stage of this in our year 2 project for CWORPH. We're doing qualitative interviews with hiring managers, and we're working to get a representative sample across states with different hiring laws and civil service requirements. And something that's on my wish list is to talk to the workforce about their perspectives about the civil service system and the protections or the pros and any cons that they perceive of the merit system and the civil service system requirements. Some recent studies that have come out have referenced that while there are critiques of the civil service system, that many of the employees that are in the governmental agencies actually see these as beneficial. And I'd be curious to know what individuals in the workforce think about these protections that are meant to be provided through these mechanisms that are now being referenced as some of the barriers to recruiting our workforce. And that's all I have from this study. I'll stop sharing, and I believe we're starting with the next presentation, and we're doing Q&A at the end.
Great, thank you. Okay, I will share my screen here real quick. All right, all good. Everybody can see that, okay? Perfect. Okay, well, thank you so much for that fascinating presentation, and thank you all for being here. My name is Paula Kett, and I'll be presenting with Bekemeier on a study that we did as part of CWORPH focused on public health nurses and their roles, skills, and training needs related to emergency response. I did want to start with land acknowledgement. This work was completed on the unceded ancestral lands of the Duwamish people, and we honor with gratitude this land, the Duwamish tribe, those past, present, and future, and their continued presence in and care of these lands. So just to make sure that we're all on the same page with what we mean when we say public health nurse and what we are talking about, the kind of official definition of public health nurse is that it is the practice of promoting and protecting the health of populations using knowledge from nursing, social, and public health sciences. And nurses, public health nurses typically refer to the people, the communities that they are working with as their clients, and they typically view their clients as the whole community or population. And so with regard to what they do and their activities, this is really based on being responsive to the needs of the communities that they're working in. And so that can include anything from more individually focused clinical interventions, or even clinical interventions at family level, to developing community partnerships, facilitating collaborations, community advocacy, coalition building, policy work, et cetera. So a little bit more background about kind of where this study came out of. PHNs are known and have as the largest professional group in the public health workforce, but we also know that the size of the public health nursing workforce has been dramatically decreasing. Since 2008, there's been a 36% decrease in available nursing positions. And we see fewer and fewer nurse staff at local health departments. They were recognized as important during the pandemic. Anecdotally, we know that they were places that had nurses available, were able to provide greater surge capacity. We also know that due to additional capabilities related to engaging the community and partnership building were a really important part of both that pandemic response and overall an important part of advancing health equity in communities. Other research has shown that they have an important combination of knowledge and skills related to an ability to work across different populations, understanding of the social determinants of health, nurse leaders. We also know that research has shown that nurses who are health directors, so nurse-trained health department directors, that their presence is found to be associated with reduced mortality disparities in the communities where they're present, as well as they've been shown to have more focus on policy activities related to the social determinants of health. And while we know that they have these valuable skills, we really need more evidence and specificity regarding their competencies and roles overall to guide academic preparation of this workforce, as well as recruitment and retention and workforce development. And specifically, one specific area where we really need this is in emergency preparedness. And so we had an opportunity to look at this for this study. So the purpose of our study very specifically was to address these gaps in understanding of the public health nursing workforce by exploring reported local health department or LHD staff nurses versus non-nurse staff roles during the pandemic. So we were curious about kind of where they reported working during that time, as well as proficiencies and skills important in an emergency response. So a little bit about the data that we used for this study. We compiled a national data set and specifically focused in on local health departments for this data set. For the individual level staff variables, so this included self-reported competencies and training needs, which I'll get into a little bit more soon. We used data from the Public Health Workforce Interests and Needs Survey that was done in 2021. And this is a survey that has been done 2 other times before, and specifically focuses on a number of different workforce components, including competencies and training needs. We also included organizational level variables from the 2019 National Profile of Local Health Departments and more community level characteristics from the 2020 Area Health Resource File. At the individual level within the PHWINS data, there were 3 different staff levels. There were non-supervisors, supervisor managers, and executive levels, or tier 1, 2, and 3 staff. And for this study, we looked at tier 1 as a group, and then we looked at tier 2, 3 as a separate group when comparing nurses versus non-nurses. One other important note about this particular version of this survey is that prior to 2021, when the survey had been fielded, it was fielded to medium and large local health departments only. This particular version was also fielded to small local health departments, so those with less than 25 FTEs or that served less than 25,000 population. And those local health departments had been previously excluded, which also, as you'll see, would have excluded a good proportion of the nurses that we have in the sample. So that was another important piece of the survey. So just to make sure that we're all on the same page when with respect to what we looked at in this model. So we looked at really two different primary predictors or variables. So first was the staff who were nurses versus non-nursing staff. And this was anyone within the PHWINS data set that had a nursing degree. So that could be an associate's, bachelor's, master's, doctorate of nursing practice, et cetera. We also were interested in looking at staff in nurse-led health departments versus non-nurse-led local health departments. And this is because of the previous data that I mentioned regarding some differences that we've seen in health departments with nurses who are nurse-trained health department directors versus not. We looked at a number of different outcomes related to competencies and training needs. And again, just as a reminder, these were self-reported proficiencies. So staff filled out the survey and were asked about a number of different skills and asked to share their proficiency as well as how important the skill was for their daily work. So with regard to each of these skills, we looked at them as a binary, proficient, not proficient, and whether or not they were a training need. With regard to the training needs, this was a composite level variable. So if a staff person said that they had low proficiency in an area, but that this area was important for their daily work, then that was viewed as a training need. We looked at the literature with respect to types of skills that were important for emergency response. And so the areas we focused on were really communication, diversity, equity, and inclusion areas, ability to engage the community and collaborate, as well as policy and data work. We looked at, tier 1 and tier 2, 3 separately. So it ended up being really 4 groups, right? So tier 1 nursing staff and tier 2, 3 nursing, and then tier 1 and tier 2, 3 nurse-led staff. And we used logistic regression to look at the relationships. So overall for our sample, we had just under 30,000 individuals in the sample, 5,600 of whom were nurses, and then just under 11,000 staff who were at nurse-led local health departments. In terms of role, the overall kind of identities in the sample, majority of the nursing staff identified as female, as white, had a bachelor's degree, and were in rural areas. Most reported program areas in kind of 3 top areas. First, 26% reported being in the COVID-19 response as their primary area, 20% in maternal and child health, and 10% in communicable disease. And this was in contrast to the non-nursing staff, for whom the largest group were in administrative, but then COVID-19 was also a very high response, as well as environmental health. And then distribution, looking at the distribution of reported proficiencies, more nurses reported proficiencies in areas like communication, diversity, equity, and inclusion, collaboration, systems thinking, and community engagement. But when we controlled for other factors in the model, we found some more mixed response. So with respect to nurse versus non-nurse tier 1 staff, we found that overall nurses were more likely to report proficiencies in areas related to diversity, equity, and inclusion, such as supporting inclusion of health equity and social justice into programs, and describing the importance of a diverse workforce. We also found that they were more likely to be able to describe how the social determinants of health impacts community health and identify evidence-based approaches to address public health. But they also had training needs specific to policy work, to use of data, both using data in decision-making and identifying sources of data, as well as engaging community members in program design, and engaging community resources to improve health. And I think just a reminder that training needs were both reported low proficiency, but also recognition of the importance of this for their daily work. With respect to the tier 2-3 nurse group, proficiencies were very similar to tier 1, so I won't go through those. With regard to training needs, they also had reported training needs around feasibility of policy and policy work overall, as well as engaging community members, strategic planning work, and collaborating across the system. Moving over to staff in nurse-led versus non-nurse-led health departments, both tier 1 and tier 2-3 staff had very similar outcomes with regard to this area, and they had higher odds of proficiency, reporting proficiency in skills related to diversity, equity, and inclusion, such as among tier 2-3 staff supporting development of a diverse workforce, systems thinking areas, including developing cross-sector partnerships, to impact the social determinants of health, cross-sector collaboration. This includes engaging with partners for use of community assets as part of addressing community health need, policy engagement, and then specific to tier 2-3 staff, organizational change management. And this group did not have higher odds of training needs in any area. So I'll move that over to Betty.
Okay, so what does this mean? What do we do with this? I mean, the findings for us really highlight areas of strength for public health nurses in terms of emergency response, particularly those related to DEI and use of evidence-informed approaches. Surely these are important areas for reaching marginalized populations, especially during public health emergencies. This advances our understanding of some of these areas where we expected to see training needs. It sort of supports previous research around database decision-making and policy development areas where we already had a sense that this might be have a training need for nurses and nurse leaders in these areas. But and clearly, so there seems to be that more support is also needed for the pipeline of public health nurse leadership. In particular, these findings around nurse-led health departments, where all the staff in those agencies or staff across both nurse and non-nurses seem to have higher competencies, et cetera, or proficiency in all areas. So that would suggest we really need to be looking at the pipeline of public health nurse leaders through academia and training and succession planning for the public health nursing and public health workforce, given their apparent value to DEI, evidence-based practice, et cetera. This engaging community to address needs was a ticklish one for us, since we have seen that as a strength in previous research. I'll talk about that in the next slide. So the next slide, Paula. So in terms of next steps, given the overall decrease in public health nurses and public health nurse leaders, it seems really important to understand what we need in terms of the public health nursing workforce, including further understanding these strengths and weaknesses. And clearly more research is needed. More research is needed, for example, around these training needs regarding this unexpected finding around community engagement. And in other prior and recent research that Paula and others have led, we've found that nurse leaders in public health are particularly strong in some of these community engagement areas. So as we've tried, our team has tried to understand that further. One explanation we've been thinking about is that that these are skills for which nurses and non-nurses rated their proficiency kind of similarly low, but as a training need, they would have also had to identify it as very important. So our sense was that nurses may likely identify that as a more important skill than perhaps non-nurses. And we found that to be true in terms of, for example, 58% of the nurses stated that engaging community assets and resources was very important for their job, compared to 46% of non-nurses. So this would suggest that nurses are perhaps differently or better recognizing these skills as important compared to non-nurses. In any case, further research is needed to better describe this workforce, where they're located, how they're distributed, their actual work functions and their impact, as well as to better understand how to assure nursing leadership and capacity in health departments. So our findings suggest that it may be really advantageous for local health departments to have public health nurses serving in roles where partnership building and ability to address social determinants of health are essential. And this would include in management of emergency preparedness programs. Also, as Paula mentioned, in terms of the leadership of public health nurses at health department leadership tends to be more in rural areas. And PH wins in 2021. We took a different approach in regions 5 in the upper Midwest and region 10 in the Northwest. And so those states had a tremendous amount of rural data was able to be provided. So we'll have more data in 2024 as more of the regional public health training centers participate and work with De Beaumont Foundation, ASTO, and PH Wins to collect even more rural data. So we'll be able to say, we'll have more data about how to sort of understand the contribution of nurses and nurse leaders. And in particular, we are finding that staff of all types at nurse-led health departments may be particularly well prepared to respond in emergencies. So these findings suggest that that local health departments led by nurses have some sort of advantage that we don't fully understand. But this should be particularly of interest to all of us as these numbers of nurses leading health departments are dwindling fast. And that has implications too for recruitment, retention, and succession planning. So final slides, Paula, just to acknowledge that part of our team is Shahida Sharir, who's also a co-author with us, co-investigator. And this work was funded by HRSA and the CDC for our Consortium for Workforce Research and Public Health, which we all lovingly refer to as CWORPH. Like Valerie, we have a paper under review for this study too, and we welcome your feedback or questions or whatever, and I'll pass it over to you, JP.
Yes, please. Thanks to our presenters, and Val, feel free to join us. We're going to do some questions from the audience. If you have more, please put them in the Q&A. We have a couple queued up here. So I'll start with one from Val, and I'll ask Paul and Betty, take a look at the Q&As. There are some here that are quick factual ones that you might be able to type back, and a couple others that are not. So Val, would you
Yes.
talk more about hiring preferences and whether there's relevant information that you found in the course of your work? The question asker says it seems counterproductive that they're not given hiring preferences since there's so many programs aimed to create pathways for new public health professionals to work in governmental public health.
Yeah, I agree. It was surprising to not see that there is any specific language about preferences for individuals in these fellowship programs. It's important to note that to change these laws is a process. So even though the AmeriCorps program was established recently, we wouldn't necessarily expect the laws to be changed already. So maybe it's coming, but I would say that it doesn't mean that agencies don't have their own processes for doing things that are meant to fast track these fellows. It's just that it's not codified in any of the statutes or regulations or the administrative codes. So from a formal perspective, it's not there, but informally, it might be put into practice. But my study, that's outside of the scope of my study because I don't know how agencies are working with these laws. I've just coded what the laws currently say.
Thank you. I've got a question from for Doctors Kett and Bekemeier that I'm going to yes and a little bit. So the question asker would like to know if in your study you saw a decrease in PHNs leaving and roles being reclassified and how that impacts the community. And I would wonder if you would talk kind of more generally about the context of public health nurses and the time trends in working in clinical versus non-clinical roles in local public health and how that's been changing.
I can start and then Betty, you can, Betty will have plenty to say about this too. I think just broadly, we don't actually have great data. We don't really know exactly how much potentially nursing positions that have previously been nursing positions are getting substituted for other types. We've heard that, anecdotally, I guess, is as far as we can go in terms of the substitution piece. But we do know that in terms of the actual numbers of reported nurses working in local health departments, that number has gone down a lot. And I think when you're asking about the kind of more individual clinically focused versus kind of this move to more population-based services and how that can change the nursing role, I'm not sure if that's quite what you're asking, JP, but that's how I'm going to take the question. I think that adds kind of complexity to the questions we have around the public health nursing role. We're currently doing a study right now to try to get more detail around public health nursing activities and functions, especially relative to what we know are can be changing responsibilities. And I think along with that comes this idea of changing identity, that public health nurses, a lot of nurses are really trained from this more clinically oriented role and not so much, population health and health equity, and these pieces aren't necessarily included in nursing education. And so when they come out of that job into their nursing role, it's something that they have to learn on the job to some extent. And I think from, my background as a nurse, non-clinical work was often not considered nursing work necessarily. And so I think that there is a tension, can be a tension in terms of what public health nurses are asked to do with regard to being more population health focused and what can be considered in the nursing world as nursing work versus not. And so there's kind of this crossover. I don't know, Betty, you probably have more to say there.
Well, just really briefly, I would add that, over time in the last couple of decades, we've seen this tremendous decrease, right, in public health nurses and health departments. And in part, frankly, some of that is to be expected as we sort of move away from a lot of clinical services. So some of that is to be expected and maybe okay. What we're finding here and want to sort of put forward is that there is also a really important place for nurses within health departments and also at the leadership of health departments. So it's not a we get rid of we have fewer clinical services, so we don't need nurses anymore. What we're finding is no, nurses have a really important place and bring a value that we need to really understand in terms of in what ways are they needed and where and how, and assure that their roles are solidified in health departments. So it's a little more nuanced than just, okay, we're not doing clinical services, we don't need them anymore.
Yeah. All right. Next question is for Val, though I think in other contexts, it'd be helpful to hear a nursing perspective as well. Val, could you speak to state level pathway programs that may exist even outside of public health? And again, for you all as well on the nursing side?
We looked specifically for all of the programs by name in our additional review. We had already completed the study, and then after some conversation realized we should specifically look for some of the fellowship programs. So we went back and we looked for those that were named in that table that I shared. But if there are other programs that might be codified in the laws, I didn't collect data on those. If it said preferences for pathway programs, it would have gotten coded as a preference. But I think depending on how you're searching the law, you might get different things. I'm not sure if I answered that well, but I'm happy to explain further.
So given that we've got a couple minutes left, I'd love to open this up to a kind of a broader discussion. We're the first in the series of several projects that are, meant to be both foundational in terms of helping to understand the most pressing topics facing the field of public health workforce, and also to move the field forward in terms of, methods, data sets, and the like. I'd put to you all, as well as to attendees, what is it that our field, for the sake of the public health workforce, is facing in the next year? What do we need to do? What do we need to know? What do we need to do better? And please hop in the chat, folks. I'm interested in what you think. Paula?
I can jump in, sure. Well, I think Betty and I feel a sense of urgency specifically around public health nurses. I think both from in other conversations that we've had, there are people saying, well, we have open positions that nurses aren't taking. And then we also have concern that we're seeing, like in our local health department, where nursing positions are, when nurses are leaving, they're being recoded to not require, so we're seeing that from both sides. And I think that there is this sense of, how do we need to address this on all fronts? This isn't just there's a data issue here in terms of what data we have available. There's an understanding of what is the best role that we have. What is the role that public health nurses need to have? They're not the only important, there's multiple important groups within the workforce. And where do public health nurses best fit? We don't really know that. We really don't have great data showing where are they most effective. But we also lack, we need to be addressing that on the education front, on the advocacy front. We need to be thinking about in the kind of what we, the more organized nursing front, really establishing, I think it's, there's a funny, I think, straddling to some extent that public health nurses have to trying to be seen as valuable amongst other types of nurses, and sometimes not, and in the public health workforce. And actually, I think they typically find more that they have, feel more value in the public health workforce side than they do necessarily in the nursing side. But the nursing side is very powerful in terms of producing these nurses. So anyway, so that's what I would say when I'm thinking about this next year. So I think in terms of like the study we're doing, that's important, but other work is kind of happening in parallel with that too.
Mm-hmm.
And just really briefly, as Paul and I, and actually a larger group of others have been kind of pondering some of this at next steps of what are the urgent things we got to sort of really get a handle on in terms of research around public health nursing is really understanding supply. And that includes, you know, the pipeline, right, from academic institutions, et cetera. The demand, what is the demand out there and for what roles, et cetera. And or what should it be if folks don't understand sort of what value nurses bring, and then what's the return on investment? We really sort of kind of are trying to hone in on those are pretty big buckets, we understand, but it feels kind of urgent. I would echo Paula.
Mm-hmm. Val, any closing thoughts?
A number of the questions that were in the Q&A I answered directly by typing my response in. But if any of you have particular perspectives that you'd like to share about your hiring experiences, I'm more than happy to add people to my interview list. I'd like to collect as many insights as I can. So my email is available in my slides, but I'm easily searchable as well at Indiana University. But I'm happy if somebody has suggestions of people they'd like me to hear from. I'm glad to add to my list of interviewees.
Thanks. So as we close out, I'd like to thank HRSA and CDC for supporting the work, to the practice community for whom we do the work, and to you all for attending the first in this series. We'll be holding these on a rolling basis for the next little while. We'll share out this schedule to you all for thank you again for attending, and we'll be sharing the slides for those who are interested. Have a great day and a good weekend. Bye.
Thanks for having us.
Thanks.